So we have this young male who has alcohol use disorder. He has a history of recurrent pancreatitis. This time he presents with abdominal pain, fever, and deranged liver enzymes. So what do we see here? So this is
Liver
post-contact.
abscess
Abscess, yeah.
and portal vein septic thrombophlebitis.
Perfect. Let's go on to other set of images.
Oh, is this like a pseudocyst fistula to the portal vein?
Yes, exactly. It's the similar case as Dr. Shekhar showed couple of months back. So this collection, do you see my arrow moving?
Yes.
Yeah.
Okay, thank you. So this is the fluid collection or the pseudocyst and looks lobulated, but this lobule is not actually a lobule. This is superior mesenteric vein, which is fistulizing with the pseudocyst. And I think I have a cine of this. So we see a lot of cholangitic kind of abscesses there. And there's pile phlebitis of the portovenous system. That's the portal vein, and we are following it inferiorly. And that's where it became SMV, and it is opening into the pseudocyst. So this is a rare condition, and it has high mortality. There's no set treatment because the number of cases are anyways less. But when I went through the literature, what they spoke was definitely making sense. Uh, Stent the duct so that there's no excess formation of the pseudocyst, and second, try and pigtail the pseudocyst. So those were the two things which came, which were they were talking very heavily about. Surgery is the last resort, but if the patient needs surgery, surgery itself has its risk of mortality. And if the patient is refractory to these conservative kind of treatments, he anyways may succumb to his illness. So that's what the literature said. That's about it for case number 1.
I have had several of these cases now, and my patients have actually done well with mostly just like conservative treatment. Like, you think it would be so devastating to have like your portal, like a pseudocyst bathing portal pancreatic juices, but they've actually, the portal vein doesn't usually come back. It kind of withers down, you get cavernous transformation, but they've actually done well just conservatively. It is interesting too about the liver, I guess, like you were calling them cholangitic
No, sorry. I think they're just abscesses, not cholangitic. I'm sorry.
So yeah, that is an interesting part here in that you don't always have, it's not always infected, but in your case, it seems like there's probably also infection going on because they look more like abscesses than just like cholangitis.
Sure.
Cool.
And
sorry, what were we saying?
These look like cluster of abscesses, and I agree, but then how would you differentiate cholangitic abscesses from just like the regular bacterial abscesses, because those also have smaller locules?
I don't think you can unless you put a needle in it. But yeah, we had this debate once with Victoria, like, when do you call it biloma versus abscess? Like, what's the difference? I think sometimes when you have really bad cholangitis, you can get these like blown out bile ducts, and we just presume that they are kind of infected,
Sure. I don't think the biliary system looks as bad. Yeah, that's the. So they are like just abscesses and not cholangitic.
Yeah, I would agree.
Yeah, thank you for that.
Okay, so this is a T2 MRI, and the finding is in the right lower quadrant.
There's this mass around the cecum.
It's like a mucosal with a little.
Yeah, there's a fluid-filled tubular structure, right? So immediately think about a mucosal. And I just want to, I'll just jump to the sort of.
Can you go to the corona?
Yep, this is the coronal.
The woman.
Oh, wow.
It's very tubular. Oh, it's very tubular looking. Has she had any kind of adnexal procedure?
Great, good job. So yes, this is a female, and this is not the appendix. This is not a mucosal. She did have ovarian transposition.
Yep.
The ovaries are now atrophic, but I'm going to show you her imaging from 10 years ago. And you can see if you follow the gonadal vessels here, they go out to this ovary that has a corpus luteum, right? And then on this side too, you can see that the gonadal vessels are pulled laterally and the ovary is over here.
Nice.
Yeah. So she'd had cervical cancer and they were going to radiate. And so they did a hysterectomy. They transposed the ovaries laterally and were able to radiate down there. And then 10 years later, just one of her tubes became a hydrosalpinx. Yep.
I don't think I've shared this case before. If I have, just let me know and I can go to the next one. But this one is supine. Patient has flank pain and the urologist ordered this. So supine, and then there is a standing.
Major thing I
Looking at the
noticed is
renal
that
shaft.
her bowel all moved down a lot. Like there's like, it goes all the way in her pelvis, most of her bowel.
Yeah, there's definitely some kind of gravitational effects. It's coming from urology, so they had a very specific question for us,
Are
which
you
was
looking for
to,
ptotic kidney?
yes, yes, exactly. So here, I could put them side by side, and then put the two.
It will not let you pick two.
I don't, that's so really sorry about that. Okay, maybe, okay, all right, well, okay, so this is supine and this is upright. Okay, so
On the upright, I almost feel like I see two kidneys on the right.
on the upright, you see two kidneys on the right. Okay. Okay, let's just make it big. Sorry, I'm sorry. I try to do it side by side and it's not working on here. But here's, all right, let's just go supine. So the supine, I see that the renal shadow is here on the right. And then on the left is a little bit higher right there. And then when the patient stands up, the right renal shadow drops here.
Yeah.
Right there. And then the left drops too, but maybe a little less. Where did I see it?
Yeah.
Like right here, maybe.
Yeah.
Right here. Right there. So I need to show you the measurement, and I'm going to do that by limiting my screen and then enabling the measurements that I drew. Okay. So this was the right one dropped from here to here, and then the left one dropped from here to here. So basically this one dropped more, the right one dropped more, and that's where her pain was, and she said that it was palpable. So this is, if the drop is more than 2 vertebral body width length, then it's that's our kind of diagnostic criteria for renal ptosis. And actually she was symptomatic, was on the right, and she actually had hydro, like intermittent hydro, no stones, things like that. And the left, there is a normal drop in the left in general when we stand up, but if it drops more than 2 vertebral body height length, then it's considered renal ptosis, especially when they're symptomatic.
I had
So
no
they can
idea about
PEC this.
this. And
they also call this like wandering kidney. That's another term that they use.
yeah, but it seems like most of our CTs, because they're supine, you wouldn't see them. Like, sometimes you see a pelvic kidney, but you wouldn't necessarily know something was wandering because it's just a non-dynamic, like supine study.
Yes. Yeah. So so there has to be a component of gravity, like a dynamic.
Cool. Question, Nelly, does like, are they going to tack up the kidney, or do you know?
Yeah, they can PEX it.
Okay.
That's the typical treatment if there's kind of refractory symptoms.
Got it.
So she's a 32-year-old female and she had rectal cancer. And in this coronal view, we see that the gonadal gonadal vessels have been like transposed towards the far right side, and that is ovarian follicle and not a cystic lesion. We again see multiple follicles below the liver, and we see the surgical clips, and on axial also we see similarly.
Cool. I
Uh,
haven't actually seen it for rectal cancer. That's but that makes sense.
the outline of the gonadal vessels are really, really great example.
Mm-hmm.
You know, when I was a resident, one of the teachings was like if you have a pelvic adnexal mass and you don't know where it's coming from, like trace the gonadals, and then it'll lead you to the ovaries if it's an ovarian mass. It's a great.
Mm-hmm. Absolutely.
Oh, it's because you have 22.
Say it
Okay.
again.
So this is my next case. It's a patient who had a PSMA PET. You can see that there's uptake in the prostate. They have a prostate malignancy, and we're looking for Mets. And there was a hot spot right here in the liver.
Mm-hmm.
So what do you guys think?
What about those hotspots when you went slightly lower than the DJ flexure? Was that just bowel?
Yeah, there's a lot of bowel activity.
Okay.
Yeah. But there was something in the liver.
That's unusual, right? Like there are benign non-prostate malignancies that do take up PSMA.
Yeah.
But
So PSMA is like this funny, like prostate specific, but it's not prostate specific at all. But a couple of things, you can get prostate mets to the liver rarely. The HCC can also take up PSMA, so that was brought up as a possibility. So we did an MR, and on the MR there was nothing in that spot. I can show you
FNH, look.
different.
Go ahead.
This is the arterial. Oh shoot, that's the sub. This is the arterial phase. Not really an FNH. This is the area. I can show you the delay. There was no washout. There's vessels going through it. Just basically nothing. There was nothing there. Okay.
So I just did a PSMA. Sorry, I just asked ChatGPT. I said, pretend you're a PSMA expert. What causes uptake? And it says FNH can cause uptake in PSMA in the liver.
That's great. But in this case, it wasn't FNH because there was nothing even on the arterial phase. There was like nothing on any phase. Okay.
Oh, okay. It feels like a total negative.
Yes, total negative. So I want to show you this, which is kind of cool. It's from my institution, a couple of my colleagues. Oops. I don't know what just happened. But so there's aberrant vascular anatomy that can give you this focal activity in segment 4, almost
Oh my
like a
gosh.
focal hepatic hotspot, and they present multiple cases that look just like my case.
Oh yeah, look at that.
And then there was like a little aberrant segment 4 artery. I did not like feel confident that I saw like an aberrant vessel, but anyway, here's another one. They present 4 cases where there's activity in segment 4 here, and no correlate on MRI.
Interesting.
That's cool.
Yeah, so it's just like a known vascular kind of anomaly, aberrant vascular anatomy that gives you this artificial focal avidity.
That's so cool.
Yeah. So
in fact, segment 4 is like developmentally also like very unique. And 2022, there was an exhibit only on pathologies of segment 4 into from RSNA. So I think you guys should check it out. It was a very nicely done exhibit.
nice. Yeah, because we know about the like veins of Sappi, like focal hepatic hotspot. Interestingly, this is also where you get the foregut ciliated foregut cyst, segment 4.
Yes.
So yeah, interesting. Cool.
So there are multiple X-ray images, and they are like one above the other. So I think this is probably just, I guess, supine. So the kidneys are not very differently placed. Similar supine. Similar. And then now suddenly in the standing one, both the kidneys drop. And then again, I think this is supine again, and they are at similar places.
So the right kidney dropped more than the left. Was the patient, did they have symptoms?
Actually, this is a very old case, so I do
Oh.
not remember the history.
I was gonna say, it almost looks like an IVP, but you know what I like about this one is that they gave the contrast. And I'm wondering, Nelly, like for your case, why didn't you guys do almost like an IVP?
Because we don't do IVPs
Oh,
here, I found out, and they stopped doing it like over 5 years ago. And it's uh, that was what the urologist ordered, was an IVP. And the tech called me and she's like, "Do we do IVPs?" And I'm like, "I've never seen one. Like I've never done one. I've never, you know." And so then I said, let's just get the supine." And when she got the supine, I'm like, "I can see the kidneys. Let's just go
yeah. You
standard."
could have done like a pseudo IVP where you not like where the real IVP is something about like taking multiple x-rays at different angles and it adds them up, but you could have just done,
No.
you give like the contrast and then do a delayed film. You know what I mean?
Yeah,
So you see like feel more confident about the collecting system. But I
oh,
think
I was very comfortable seeing the renal shadows on the non-contrast radiograph. And yeah, I guess it would have been interesting. That would be my first IVP in all of like my time in radiology. But it turns out we don't do it. We just don't do it. So like, okay.
Even we guys have stopped doing IVPs, but when I go back, I'll show you one interesting case.
Do you guys do IVPs in Emory?
No,
Or
well,
Iowa?
we don't do them, but we've done them occasionally. It's not like we have a rule like we don't do them, right? But we don't do them routinely, but on occasion we've done them.
Oh.
And then I remember like, looking at a bunch for like oral board prep kind of thing. So it's more like a theoretical knowledge of these IVPs and stuff. But
Oh, I see. Yeah, technically I could see how it could be, but it like really complicates the process because would need to get the IV line, we have to get this and that, all these like procedures in place because of contrast.
yeah. But that's where like, because the old IVPs, it wasn't just you give contrast and take an x-ray. It's like there's something about it where like everything else looks like it's in motion, but except for the kidneys.
Mm.
But anyway, hold on one second.
This is a patient with UC, had at some point a diverting colostomy. You can see that here, transverse colostomy, just to help cool things down. And patient is pre-op for colostomy takedown. And so our colorectal surgery team got a pre-takedown enema. So here are sequential images.
is there a fistula? Two
Yeah,
tracts.
tell me what you're seeing.
We see two tracts between at the place of sigmoid.
Yeah, so here it is, right?
Mul-
And go ahead. Uh-huh.
Sorry, multiple tracks, not two, more than two.
Which then
Uh,
raises the question, is it truly UC or is it Crohn's?
yes,
Crohn's.
good, excellent. Yes, so here's a cine. So you can see that there's, as both of you have already described, there's tracks, right? Here. And then if you look back on the CT, it's really hard to tell, I bet, like prospectively, but in retrospect, you actually see this intramural tract right there. There's one here. You can, it's not, patient is diverted, right? So it's completely collapsed and you're not going to see. But here you see one lumen upstream and then downstream, that one lumen, maybe the main one's here, maybe, but you're starting to see something because there's pretty pronounced thickening here. And then maybe it's a little bit more obvious here, right there. It looks like kind of to me like a necklace almost. So the about 20% of patients with initially diagnosed with UC get reclassified as Crohn's. And that's just something that's well known in the IBD world, that it's sometimes hard to separate those two. So this patient imaging had primarily, actually only isolated colonic disease. So it's not always clear up front what they have.
Yeah, and sometimes even on path, it's like there's like overlap between the pathologic findings on biopsy. What's cool about that case too is like, a lot of times we don't really use fluoro anymore to like diagnose IBD. Like we use CT enterography, MR enterography, but in this case, the fluoro really actually added to the diagnosis and like the seeing things better, because you couldn't really see the the tracks as well on CT.
Yes, agree. I think exactly. I think you could not make those. You couldn't make that diagnosis without the fluoro.
Yeah. Cool. Okay, this patient had prior contrast, recent contrast administration, and got this like non-contrast exam.
Lymphoma, IgG4, Ardem Chester.
Okay, great thoughts. Initially this was
Wait, what's the crit? Sorry.
yeah, so that was the
What's
other question, like, could this be hemorrhage? They were anemic. What do you think? Okay, maybe could be hemorrhage on the, this is the non-con.
Extramedullary.
And then this is the post-con. Do you think it's hemorrhage?
No, oh, it looks dense.
Extramedullary.
It's very dense. So, okay, so,
Oh, I see. Yashant said extravasation. Something fat.
Extramedullary hematopoiesis.
Oh, no, sorry.
yeah, so it's not extravasation, it's enhancing. This is all infiltrating, enhancing tissue. So far it's been brought up lymphoma, IgG4, Erdheim-Chester, extramedullary hematopoiesis. Those are great for retroperitoneal soft tissue.
The
That
retroperitoneal fibrosis.
okay.
I don't know if we've already mentioned that or not, but
Yep, and that could be in like the IgG4 spectrum, and it does look like it's obstructing the ureters and causing hydro.
well, the cecum looks really thickened. Or
Yeah,
like the right lower quadrant. Oh, carcinomatosis.
yeah, great. So really bad carcinomatosis, like I've seen really bad, for example, prostate cancers or squamous cell carcinoma grow like this. I'm going to show you 3 months prior. This is what it looked like.
Oh, wow.
So there was definitely enhancing nodules and soft tissue here, right? And it was
Super, like very intense. Like the enhancement is pretty pronounced.
yeah.
Is it
Yep.
like neuroendocrine tumor? I mean, that adeno doesn't really have that, or maybe it does. I don't know. Maybe it's the phase.
And then
Is
I'm
it
just
adeno?
no. I don't know if it's not the most obvious here, but let me just show you some osseous findings as well. There's like lots of little tiny lucent lesions.
Oh, like plasmacytoma.
Yeah, so this patient had multiple myeloma, and then this was just aggressive plasmacytoma that had progressed rapidly within 3 months. So,
Wow.
yeah, but I've now seen a couple of cases of this where it can be really tricky on a non-con where it could look like hemorrhage, but definitely, especially if they have a history of plasmacytoma or anything looks more bulky, like you're saying, like soft tissue here. Even on the non-con, I would say that this does not look like hemorrhage, right? Maybe some of this stuff could have been hemorrhage, but have a very low threshold to get a post-contrast exam, see if it's enhancing, and then you probably need to biopsy it. They did end up biopsying this, and this was plasmacytoma. So,
Wow.
yep. And then the history, obviously, if you have bad multiple myeloma.
A patient has pancreatic findings.
I saw like a couple of little either
Yeah.
or fatty things.
Oh, okay. So yeah, this is probably fatty here.
Yeah.
But this one, what do you think about this one? Patient has a GU oncologic history, but also has like known pancreatic hypodense findings on.
Can you scroll through that? Is it like measuring fluid or fat?
This thing here?
Yeah, it looks like fat.
It's not.
Okay.
I don't think it's fat. It is hypodense, but it's not fat density.
Okay.
I can
Is
measure
it a
for you.
rim of enhancement around it, or is that just vessel?
Yes. No, it's a rim.
Okay. When I think about cystic lesions with a rim, I think about like cystic neuroendocrine tumors. Less commonly MCN. Usually IPMN doesn't have a rim. It has more of a papillary nodule.
Wait, what has a papillary nodule?
Like IPMNs, when they have a
IPMN
component, it's not like usually a rim of enhancement. It's usually a papillary component. The ones with rim is mostly like neuroendocrine tumor, cystic and solid can be SPEN, and then MCN usually also has like a solid nodule, not a rim.
Good, good, exactly. And on prior studies, it was not centrally hypodense. It was just like
Yeah.
uniformly enhancing. I don't know if you can see it here, but like here. So it
Subtle.
became hypodense, yeah. And we have a confirmation dotatate study here that shows
Nice. Neuroendocrine.
uptake on dotatate. Yep. So cystic neuroendocrine tumor, I mean, you've basically said it. If it has like a rim of enhancement, it looks different from others. And that's the classic appearance, is that rim of enhancement. So, and there's genetic diseases that are associated with cystic neuroendocrine tumor, like EMEA type 1.
And in general, cystic net is better prognosis than solid net. But even so, it's a small one. So, you know, sometimes
Yeah, it is small. They could just watch it. Yeah.
So this is a young male who comes with acute right-sided scrotal pain. Ultrasound of the scrotum is done and it is absolutely normal. The patient is also a known case of Crohn's, and we see that there is this wall thickening of the bowel. There's also this inflammatory phlegmon in the retroperitoneum, more on the right side, and the patient also had testicular pain on the right side. So basically, this inflammatory phlegmon compressed the L1 ilioinguinal nerve root, which we don't see, and that caused the referred scrotal pain. So this was kind of cool, so I thought I'll just share with you guys.
cool. So actually our MSK people do MR neurography.
Mhm.
And this, like, for example, the genitofemoral nerve, like whenever we have, I don't know, they're questioning about like referred nerve pain, I always call my MSK colleagues because they're really good at like being able to like see and label all the nerves. So I've learned a lot from them, but yeah, this, like you're saying, on a CT, we would never see it, but on MR, you can actually follow all these nerves.
Mhm. Also, I wanted to show you this. This is the exhibit I was talking about, segment 4 from 2022.
Oh, cute. Fantastic Four. Very nice. Yeah, and actually that last case on the top is probably an MCN. I was thinking that also affects segment 4 more and left lobe more.
Mhm.
Nice. We will have to check it out.
Okay. This is a patient who came in with abdominal pain. This was, I have an older study, and all of it was normal, but there are findings that are now complicated. Yeah.
I feel like I see small
Uh,
bowel diverticula. So maybe
Yeah.
small bowel
Here, and then if you keep looking, there's like a lot more.
mm.
Like here.
Does the
Yeah, and then
patient
go ahead.
Sorry,
What?
does the patient have connective tissue disorder? Each time I see small bowel diverticula, that's one of my thoughts.
That's a great question. I don't believe the patient carried a diagnosis of a connective tissue disorder. Yes, we don't have a history, no known history.
Okay.
And then patient got follow-up imaging, and the patient was treated conservatively, and it all resolved. Antibiotics.
Wow. And can you see the diverticulosis here? Like, I feel like it'd be easy to miss because they're not popping out as much. Oh, yeah. Nice.
Oh, sorry, not this one here, but with jejunal diverticulitis, I feel like the more you look, the more you see.
Mm-hmm. Very cool. So this is a patient who had a renal transplant. About a month prior.
Oh,
Pygelian hernia
wow.
of the kidney.
Sorry, what'd you say?
Pygelian hernia of the kidney, transplant kidney.
Yeah, good. So you're saying Spigelian hernia, which I think maybe technically that's what this is, but what they called it was a fascial dehiscence at Gibson's incision. So when they do a renal transplant, they make what they call a Gibson in his incision. Not important to know the name, but whatever, just happens to be that. And they place it extraperitoneal. So it's outside the peritoneal cavity, but underneath the external, like the musculature, and then that linea semilunaris, where you're saying like could be a Spigelian hernia. So yeah, this is what they just call like either an incisional hernia or a fascial dehiscence. There's a couple of different things that can happen. It can actually like just kind of go through the fascia, or it can actually go through the muscle. In this case, this patient went to the OR. So there's a lot of different factors that will determine whether or not they're going to go to the OR, because usually the renal transplant doesn't really torse, like the vessels are preserved and it doesn't actually impact the kidney, but it can cause a lot of pain for the patient. They have to wear an abdominal wall binder. It can cause a lot of discomfort and just anxiety that like that something, something's going to happen to the kidney, right? Because it's like bulging right under the surface. And so if they're younger and they're a pretty good surgical candidate, they will try to fix this. In this case, they went to the OR and the entire external oblique muscle had ruptured. So they were able to reoppose the internal oblique and the transversalis, these two, but the external oblique had ruptured, so they had to put a biological mesh. And they actually also ended up intraperitonealizing the kidney. So even though normally a transplant kidney is extraperitoneal, there wasn't enough space given the herniation. So they made a peritoneal window and then put the kidney intraperitoneal, put like sewed together the other muscles, and then also for the external oblique that was ruptured, they tied it together. The defect was too large, so they tied it together with a biological mesh. So anyway, like, the first time we saw it is like, oh, is it just bulging? Is it truly a hernia? Like, when do we call it? But this was bulging too much. This is a hernia, and they will treat it if the patient's a decent surgical candidate.
Cool. Yes, I am. So that's diverticulitis of the appendix.
What? There's
I
so
have,
many
yeah,
diverticulitis. So cute.
yeah. I have diverticulosis of appendix, but I do not have a case of diverticulitis of appendix.
That's
I've
good.
seen at least 2 cases of diverticulosis of appendix.
It never even occurred to me that the appendix could have diverticula.
I have a case of diverticula of Mickel's diverticulum.
What?
I
All
will
right.
show you next time when I'm like back.
Okay. Yeah, for those of you out there, Yashant is beaming in from India. So we've gone international. Okay.
Okay.
That last case of diverticulitis of appendix was from RSNA 2024.
Okay. So someone else's exhibit, you're saying?
Yeah, not mine. Yeah.
Okay.
So this patient, Aarti, I think I might have presented this case already. If I have, just let me know.
There was some mass behind the vessels. What was that?
There's 2 findings, unrelated. This is the first.
I see fluid. Obviously, that's not the finding. And then, like, wait, is there something up with the rectum? Sigmoid? No.
Focus on the appendix.
Is it dilated?
Um,
Like fluid filled and dilated?
yeah, it's fluid filled. So here it is. And then
Oh, and it
at the,
has like rim calcification. It's like a ruptured
okay.
mucosal.
Yes, 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 yes. So yes, so let me just on the axial, it's right here.
I would say that's a great call, because it's like it's kind of subtle with all the fluid around it, but the
Yep.
calcification definitely is a clue.
And then there's a attenuation difference between the wall versus the fluid. And then
Yep.
there's a rupture, like at the base. And then there's a incidental finding that's also significant in the colon.
Something about the left colon. What's up with that?
Yeah. Yeah.
Hyperemia. Oh, a mass. There's a colon cancer.
Yep. Exactly. So the
Like
patient
a
had
densely enhancing circumferential with a lymph node next to it.
Yep, right here. Good. Yeah. So keep looking.
Wow. True, and unrelated. So this is a 25-year-old male.
Some kind of like infectious inflammatory process happening. Lots of little nodes, maybe reactive. The ileocecal. Can you show me the sagittal?
Uh-huh.
There's like
Interesting you want to
air.
go to the sagittal. I hate the sagittal.
I love the sagittal. For the pelvis, I love the sagittal. Okay, so bladder, it's just not, well, the bladder and the prostate
Bladder's
looks
down here.
fine. Yep.
Yep.
So it's all happening around the bowel.
Mm-hmm.
And there's pneumatosis or something happening in the right cecum or something.
I think it's okay.
Okay.
But the big question is kind of what you brought up, like, is this inflammatory? You know, and they're young patient, a region of the appendix, like, is this a perforated appendicitis? What is this, right? But anyway, this is now, I think I was showing you the non-con before. This is the post-con. It's kind of like mildly densely enhancing. There's a bunch of lymph nodes. There was a little debate, you know, is this some kind of exploded inflammatory process, or is this too much soft tissue? We decided it was too much soft tissue. They actually biopsied it like right here. And this was actually Burkitt's lymphoma.
Wow.
So I think it's kind of almost like my plasmacytoma case. Like if it looks too dense, if it looks enhancing, if it looks like soft tissue, like even if they're young, don't jump to like infectious inflammatory. And then there was all these lymph nodes here too, which could have been reactive, but kind of too many. But anyway, yeah, so this was Burkitt's lymphoma. So just a couple of teaching points. It's much more seen in children. It has a 4-to-1 male to female predominance. There's 3 types of Burkitt's lymphoma. There's what's called the endemic type, which is seen much more commonly in Africa. That's related to both EBV and malaria. There's spontaneous, which is usually seen more in adults. That's what this might be. And then there's the immunosuppressive type, like patients with HIV or immunosuppressive therapy can also get Burkitt's lymphoma. And then the main sites are, it can be anywhere basically, but like in the head and neck, pleura, and then it loves actually the ileocecal region, but can also just be in like in the pelvis and the retroperitoneum and the mesentery. So yeah.
Great case.
Yeah, the endemic one is more commonly, the endemic one in the African subcontinent affects more commonly the jaw, and this slightly more adult case, they affect more of the abdominal cavity.
Got it. Cool. And Burkitt, I learned, was a physician who worked in Uganda in like the 50s or something, and was seeing cases there. Let me look it up again. Let's see. Oh, I don't know where it is. Okay. Anyway, he was in Uganda. Yep.
So this is a 63-year-old female. History does not help as much, but she comes with an abscess behind the urinary bladder. So we see this is the abscess behind the urinary bladder. This all stipple calcification is the calcified fibroids, and that's the abscess. That's the abscess. So this abscess is drained, and the patient is given the antibiotics, but there is recurrence. And do you see the another screen? Another slide? Do you see that?
Yes.
Okay. So I followed this patient for quite some time, and at least 4 times she presented with abscess in the similar location. kind of identical. And the other thing which was identical was this hyperdense focus in this abscess. Any thoughts what's going on? And all of the 4 times, the patient had the abscess in the same location behind the bladder.
A nidus of some sort.
Yeah, like a dropped gallstone.
Uh,
Although that's usually a little more posterior, like in the
Has the
pelvic.
patient had procedure done?
Patient had a procedure done, yes.
So some kind of like a sacroplasty or what kind of procedure?
Okay, I will
Or
show.
sorry, colposacropexy.
Basically, this is like the first scan before anything of this happened. So this is the bladder, and we see a hyperdense focus, and we see a structure, linear structure. Oops, sorry, my video is not playing. So sorry about that. So this linear structure was nothing but appendix, and this was appendicolith, and there was subacute appendicitis, and the appendix had kind of fused uh, fibrous adhesions between the appendix and the urinary bladder. So when the appendix was removed, the appendicolith dropped down. So it was dropped appendicolith causing abscess.
Nice.
As a companion to, like, we see dropped gallstones. So dropped gallstones will be more around the liver or along the port side. And
Although they can drop into the pelvis, like into the cul-de-sac.
yeah, they
It would
can.
be
And
surgical, right? Like they would have to go in and actually remove the nidus. No?
yes, yeah, they have to remove the nidus, otherwise it will keep recurring. And one of the causes for pelvic dropped gallstones would be transvaginal cholecystectomy.
What?
Yeah, they do. Like for cosmesis, although like the laparoscopic one that we do has minimal incisions than the open one, but to avoid even those 3, 4 small incisions, there's this transvaginal cholecystectomy.
They can also do transvaginal hysterectomy.
Mm-hmm.
It's pretty
That makes
incredible what they
sense
can
to
do
me,
now.
but a transvaginal cholecystectomy seems a little bit far.
Yeah, there was a case when I was an intern, as part of a clinical trial. It's like part of this notes procedure, natural orifice surgery, minimally invasive surgery.
Wow. Cool.